Today's Asthma Management Academy's webinar topic is how California asthma home visiting programs are adapting to COVID-19. My name is Esther Bejarano, and I will be moderating today's webinar. This webinar is part of the Asthma Management Academy, which is provided by California Breathing, California Department of Public Health and Asthma Program, and Comité Cívico del Valle. AsMA is a professional developmental opportunity developed in 2016 by the California Department of Public Health for community health workers and health educators to lead participatory national asthma guidelines-based education to encourage asthma self-management education and prevention for their patients and clients with asthma. Before we begin, I would like to start off with some webinar logistics. Everyone on the webinar will be muted throughout the webinar. If you have a comment or question during the presentation, please use the question window to enter your question. We will have a question and answer session at the end of the presentation. We will try to respond to as many questions as possible. This webinar will be recorded, the webinar, so that you can play it back in the future. At the end of the webinar, there will be an evaluation. Please take a moment to fill out the survey to help us make each webinar better. And again, we would like to thank you in advance for your participation today. We are very excited to be with you today. You will be listening from our 4 asthma home visiting programs from across the state. You will hear on how their programs have transitioned. We continue to transition and learn due to this COVID phase. We want to thank all of our 5 expert speakers today for their time and dedication to make this webinar possible. Okay, great, let's get started. I will now introduce our first presenters. Our first speaker will be Anna Rivera and Kevin Hamilton. They are from Central California Asthma Collaborative in the Central Valley. Anna is a graduate from California State University, Fresno, where she obtained a Bachelor's of Science degree in Public Health. She has established herself as a key advocate for asthma patients through her work in the Asthma Impact Model Program and as co-chair of the Asthma Coalition of Kern County, as well as a community leader through her participation in AB 617 Community Steering Committee process in chapter. Kevin is a registered respiratory therapist, asthma clinical specialist, focused on reducing the burden of chronic respiratory disease and environmental health impacts valley-wide. He has served as a developer, coordinator, administrator, and director for multiple programs in both hospitals and community-based settings, serving poor and underserved communities in the San Joaquin Valley for 35 years, and is a well-known advocate for social and environmental justice. Thank you both for being with us today, and we will now hand it over to you. Thank you again for being with us.
Thank you so much, everyone. This is Anna Rivera. It's such a pleasure to speak with you all. So today, Kevin and I will be presenting on the Asthma Impact Model Program and how we're adapting during uncertain times. So just to begin with a little bit of background information on what the Asthma Impact Model Program is. So this is a 12-month multi-component asthma intervention strategy. So in this program, we provide folks with health education. So this would be helping them identify what asthma triggers are, giving them a basic understanding of what asthma is and how to properly use their asthma medication. We also conduct a home environmental evaluation, again, to identify those asthma triggers and help the participants identify how they can reduce those triggers in their home in ways that are free or low cost. We provide them with case management and make sure that we connect them to any resources if they are housing or food insecure, to make sure that they're actually able to focus on their asthma. And we facilitate and reinforce regular visits to their healthcare provider. So every month that we give them a call, we check up on them and see if they've already gone to see their primary care provider. If not, then we encourage those visits. We are also able to go with them, and during these times of COVID-19, we can be with them on the call over the phone to make sure that if they have any questions, we're asking those questions during their visit with their provider. We also provide them with tools to improve their asthma management. So for folks that participate in the program, they can be eligible to receive some items such as a HEPA vacuum cleaner, asthma-friendly cleaning supplies, a spacer for their inhaler, integrated pest management, all things that would help them better manage their asthma. And we support long-term self-management. So not only do we help provide support for folks while they're in our program, but we still follow up with them after they completed our program every 3 months just to see how they're doing and connect them to any resources if that's necessary.
So one of the big issues we faced moving out into the virtual meeting arena is privacy and security. Probably one of the most important things that any of us face in doing this work is how do we, in small community-based organizations such as ours, match the security, prevention, and guarding of patient health information, private health information. So we were forced to update our systems pretty significantly. Luckily for us, the payroll protection program came along with the disaster loans, and we were able to qualify for both. So we were able to use some of that funding to not only update our consent forms and other paper processes, but also update our internal hardware and software, bringing us up to the federally required standard for protecting health information to what's called 256 AES standards. I don't know about the rest of you, but for myself, this was a huge education on the IT side. I had no idea we already had 128 AES standard. I still am not sure what AES means, quite honestly. I have it written down somewhere. It's not something I feel I need to know. Happily, we have an IT guy who is just top notch and also works for the university. So he was able to come in and help us get this going and get it set up. We are the last wall, if you will, between our patients and their information being shared out over the internet. And we know there's people out there who are predatory and anxious to get at that information. So this allowed us, as it says here in the bullets, to not only purchase the hardware, but update and write new administrative policies that had to be approved by our board. Pushing these security software updates really made it difficult for us to operate for a couple of days. And we had to actually add additional security for our little small closet we call a server room, in case somebody wanted to break in and steal our servers. So it was pretty insane, but it's all done now, and we feel confident that our patients' health information is well protected. Next slide.
So prior to a virtual visit, we give the patients a call and provide them with a program overview. And then we ask them if they are interested in participating in a virtual visit. And if that's something that they have access to, do they have access to a device where they can use video? Do they have access to internet? And if all those boxes are checked off, then we begin collecting their information. If they're interested in participating, but they don't have access to those, then we can see what resources are available to them so that we can make sure that they are included in a virtual visit. But so far, that's not something that we've encountered. Fortunately, all folks that we've encountered and enrolled in our virtual visit program have not had issues with access to a device or internet. So once we collect their information, then we go ahead and schedule them for a virtual visit. We do 2 separate scheduling. So we do the date of the virtual visit and then an additional date to drop off some consent forms and informational material, as well as a few items such as a spacer and humidity monitor that we will be using. the day of the virtual visit. And when we are dropping those things off, we make sure that we wear a mask and gloves, and we drop them off at the doorstep of the patient on a day that they know that they're available to pick up those forms. In preparation for the virtual visit, we do practice going over those consent forms through the video platform that we will be using. So that link is sent to them, and if they do have any issues logging on, then that's the time that we're able to troubleshoot those problems. And so far, we haven't had any issues with folks not being able to connect to the video platform and log on. And then we just remind folks that before their next appointment, since they will be using a device, making sure that they do charge their device so that we are able to complete the entire visit. We also take this time to identify if there are any barriers, like if they have any mobility issues that might make it difficult for them to walk around the home during the home assessment. And if so, if there's somebody else in the home that can help, they would just need to take the device around the rooms in the home to help me identify those asthma triggers. But if not, then we can try to see if we can complete most of the home environmental assessment questions and as much as we can while the patient is sitting down, and just seeing what resources are available to make this accessible to them. So the day of the actual virtual visit, since this is a process that we would usually do all in one go during our home assessment, and this is a pretty lengthy process, so it is about 2 hours to do the initial enrollment for our program. So we do want to be mindful of how much time we're taking and how quickly their battery is going to be used up. So we do split it into a phone call and a video call. So we do the first portion as a phone call where we collect information and we do the needs assessment form. So this is just collecting basic information on their demographics, on their utilization of like the emergency room, the hospital, urgent care. Also, if they need any resources, this is the time that we're able to identify those. So if they are connected to CalFresh or they're not connected, making sure that we make a list of all resources that are necessary for the patient. And then we do a few questionnaires, the asthma control test and the quality of life questionnaire. So this is information that's self-reported from the patient, and this is information that we will collect every time that we give them a call, just to kind of see how they have been progressing through the participation in the program. Then we will move on to the video call portion. So during this portion, we start off with a medication log after we've identified what medications they're using. To make it a little bit easier to collect that information, we just have them hold up their medication to the camera, and we'll snap a picture of that, and that way we can create a medication log. We also make sure that we use this time to see if they're using their asthma medications properly, making sure that they have the proper technique, and if not, we guide them through that. Then we move on to the environmental home assessment portion. So we just go throughout the rooms in the home and identify areas that may be harboring those environmental triggers. And on the way, while we're doing that home assessment, we provide them with those tips that are free or low cost to reduce those triggers. And we provide positive reinforcement for the things that they are already doing correctly. After the home assessment, then we identify 3 goals that they can work on to reduce those asthma triggers in the home. We want to make sure that they feel that these are goals that are manageable. And every month that we give them a call, we follow up to see how they're doing with their goals and if they need any support or if any of those goals need to be adjusted. So once we completed the virtual visit, then we schedule an additional time to drop off those remaining incentives. So since we only provide the spacer and the humidity monitor, then we take that time to drop off those other incentives that they may qualify for. And if they want to be connected to any other resources or if they need help applying for public housing, then we'd schedule an additional visit as well to complete those over the phone. And what I really like about being able to do this virtually is that we are still able to use like sharing our screen. If they are having difficulty answering some of the questions, sometimes it does help to share a screen so that they can see what the questions are, and some of them have a lot of options. So this is where you can reach us, our contact information for myself and for Kevin. Thank you.
Thank you, Anna and Kevin. And thank you for sharing those detailed steps in your new shift to asthma home visiting programs. With that, we will now move on to speaker number 2. We will now hear from Destiny DeWalt. Destiny is promotora at Esperanza and has worked for a decade in South Los Angeles, serving the community as a case manager and promotora. She has worked at Esperanza as a community coordinator and also works as a doula. She has recently been working on doing virtual home visits for clients with asthma due to COVID-19. We will now hand it over to you, Destiny. Welcome. Hello, Destiny, can you hear me? You've got the mic now, Destiny. Apologies for that. We're having a bit of a technical difficulty with testing. We will move to our third speaker, and we will get back with Destiny in a moment. I would like to now present our third speaker. We will now hear from Brenda Roda Yamashita. She has been the director of the Chronic Disease Program for Alameda County's Public Health Department for over 18 years. Prior to coming to Alameda County, she worked for 3 years at the California Department of Public Health, Diabetes Prevention and Control programs promoting the use of evidence-based guidelines for diabetes care in medical groups and HMOs. Brenda has experience in diabetes and asthma in both the adult and pediatric populations. She is a past chair of the Diabetes Coalition of Asthma and locally participates on the Ethnic Health Institute, EHI, Chronic Disease Committee. EHI is a foundation of Samuel Merritt University. Brenda, welcome.
Thank
We
you.
will now hand the mic to you.
Thank you. So I want people to just think a little bit as they hear each of us speak that we're all coming from different types of organizations, and you will all be from different organizations. So you will each run into different situations that you're going to have to look at when you're trying to do something like this. We're all going to have different experiences, but it's great that we're getting to hear each other because it will really help all of us mold how we will do this in the future as well. So the Asthma Start program is part of the chronic disease program within Alameda County Public Health Department. It's been in existence since 2001, and it is a in-home case management. We serve 0 to 18-year-olds, and our county consists of 14 cities. So we go throughout the county doing this type of work. Our base people who are our asthma coordinators are social workers. So we're looking at asthma and all of the issues related to it, as well as any social determinants of health or psychosocial issues that the client may have. And because we are a public health department, we are not a clinic, we are not a hospital. The people we work with are not our patients. So we call them clients. It makes it slightly different because a relationship hasn't been developed. They're not the patient who we've seen month in and month out. And so now we're, going to work with them, and they trust us because they already know us. When they're coming to us as new, they've never met us before. They don't exactly understand what we do totally. And so it's a little bit of a different sell when you're doing that. And in this situation, it's a little different as well because you're calling them for the first time. They've never seen your face, and you want them to trust you. So there's things to deal with around that. And one of the things the public health department had to do is several years ago, we had to decide if we were considered an essential 1, 2, or 3 service, 1 being the most urgent, 2 being the second, and yes, those services would need to continue. And we had determined at that time we were a 2. And in our particular department, which is Community Health Services, there are only 2 of us that fall in that category. WIC, because they can't shut down and stop serving the women, infants, and children, and ourselves, because we figured that asthma clients were going to need us. But when developing all this, because we live in California, the disaster we thought we would be dealing with was an earthquake, not a pandemic. And they're very different. You have to think about things in a very different way, because we're talking about, contagions and people being exposed to it, and how are we going to protect our employees as well as our clients, and so on. So there was a lot of avenues we had to look at. We were one of the first of 6 counties to go into shelter in place. And we were told as of March 13th, you cannot do home visits. You cannot go into people's houses. So at that time, we had to sit down and say, okay, so what are we going to do? Because we are this essential 2 service, and we need to continue to serve people. We had hundreds of clients we were working with currently that had either had a first, second, or third visit. They were ready for discharge. Maybe they were in the middle of management. And so we had to figure out, how are we going to address that? How are we going to keep up with that? As well as we had 299 referrals we had just received from our managed Medi-Cal. And then it was like, oh my God, what are we going to do with all of these people? And so what we did is we sat down to strategize, how were we going to approach this? Because none of us have had to approach this, a pandemic in 100 years, and an actual disaster that required us has not happened the entire 19 years I've worked here. So we all could have been more prepared. And so what we decided to do is that we agreed we really needed to keep in contact with our clients, our current clients for sure. So we would call them monthly and check in with them and see if they had questions. Did they have questions about COVID? Did they have questions about their asthma medications, asthma in general, any issues around social determinants of health or psychosocial issues? And so we decided, okay, we're going to call those people monthly, but we still have this big list of people that we had been referred. And these people were the ones who didn't know us. And so we decided that we would send all of them a letter stating that their insurance had referred them, that we would very much like to help them. We could not do home visits right now, but that we would contact them as soon as possible to try and work with them. And we mailed that letter out to all of them. We gave them a phone number to call us if they had questions, and we also gave them some information to remember about COVID, about washing their hands and everything else they might need to know. So, and then shortly after that, we decided, you know what, we need to start contacting these people. And so we have started to do telephonic contacts with them as well. We decided that telephonic visits, is what we'd have to do, what would be required. But then there was a lot of questions around that, like what system would we use? What system was HEPA compliant? What system would the county allow us to use? And everybody pretty much went to Zoom right away. A lot of people were on Zoom for various types of meetings. And then there was a lot of meeting bombing going on, which did not work well when you're trying to be HIPAA compliant. We actually the county received a memo from the FBI telling us not to use Zoom, that was not an appropriate way to go because there was not enough control around it. So we still had our phones, of course. We could call people and we could do it that way. And we ran into some of the same issues that were just spoken of. We had to make sure their batteries were charged on their phone. So if we had to spend some time with them, the phone didn't die right in the middle of our conversation. We had to introduce ourselves over the phone, which is a lot harder than when somebody can see you in person. But we did it, and we've had pretty good acceptance from a lot of people. Some people may be a little leery. They don't know who we are, but others have been very accepting. And we don't know, is it because they want help? Is it because they want somebody to talk to? What is the reasoning behind it? But they've been fairly receptive. And so that has been a good byproduct of it. We also looked at, okay, but we have all these forms we want signed, consent for service, the HIPAA forms, a release of information form, and how were we going to do this? So we had to do some research around that. And, we checked in with several different sources who it would be important to, that these were filled out correctly. And we found that verbal consent was okay, but that we had to notate that, and we had to make sure it was documented, that we could show it at any time that somebody requested it from us. We did try to do some mailing of forms and having them mail them back, putting a self-stamped addressed envelope inside. That did not go as well. So we pretty much go with the verbal consent. We also had to look at, there were some services that you could use that would actually bill the person on the other end. There were some that were not free services. So we had to be careful of that too, because we didn't want to create a bill for somebody. And then we also do billing. We bill insurance. We bill targeted case management, which is a state federal type program. And so we had to go to those groups and say, if we're doing a telephonic case management, can we bill for telephonic visits? And that took a while. They all checked into it and got back to us within a couple of days saying, yes, we could do a telehealth visit. So we have been able to continue to bill for our services by using telehealth. And then, so we knew we could do intake, and we could do a lot of the forms that we fill out on the first visit, which usually takes about 2 hours, on the phone, because we could just use our same forms. We could go through, we could ask our questions, and so on. But when it came down to the visual part of it, it was like, okay, so what are we going to use? What are we going to use that is HIPAA compliant, that we have access to, and that they have access to? And one of the things that worked best for us was using WhatsApp. And I've been told that WhatsApp is encrypted at both ends, so it's fairly secure. It also was rather prevalent in the populations that we were working with. They may have used it to contact relatives in another country. They may have used it when they went on a trip, but it was fairly well known and accessible to them, because Teams that we use and Zoom and so on wasn't as easy necessarily for them to get onto, and you had to walk them through how to apply for the app and how to get things on their phone and so on. So the WhatsApp is what we use to look at the home. So when we finished by way of the phone, sorry, that phone should not be ringing. When we finished by way of the phone introduction and filling out the paperwork, we would then switch to WhatsApp, and we would have them take us through the house to look at areas we needed to see, either areas that they were identifying as being an issue, like I have some mold on this wall, or I have this leaking pipe. They could show us by way of the phones. And then we were able to start to address some of those with the property owner if need be, or it may be something that we could easily have them change something and it would be helpful. We would watch them. They would show us their meds so we could see what they were talking about. We could see some med administration. We try not to talk too much about asthma because we want to make sure the line is secure. But we can talk about the other things that we see. We also supply asthma supplies, such as vacuums, pillow encasings, mattress encasings, several different things, non-bleach-based mold cleaner, and so on. And so we came to realize, okay, so we've done the first part of the visit, and our second part is where we would normally do this. We need to figure out how we're going to do this. So we decided to do what we call porch deliveries. And we would call the person first and say, we're going to come by with your product. Are you home? Are you there? Will you be able to pick it up off the porch? And once we got that confirmation, we would set up a time with them. We come with gloves and masks and go up to the porch, drop the things off. We back away from the porch at a good distance. We call them and say, your things are out there. We watch them come out and get them. And then we have an acknowledgement that they've received it. If they have questions about how to use it or any other issues, then we will go ahead and hook them up to that, and we'll get on the phone with them, talk about it, and help them with whatever it is they need. So we found that this might be a viable way of doing some of our visits, even when COVID is over. because some people seem to be more receptive. It is not the best way. We need to see the home. And one of the things we decided is with these clients where we had never seen their home because they were new, we would not discharge them till we had an opportunity to see their house at least once, because often the house has the hidden secrets as to why things aren't working well. So we will follow up on that. It may make the people stay with us a little bit longer than usual, but that's okay because we want to make sure we get things done right. We have found that this is an acceptable mode for people. And in some cases, it might be the way to get our foot in the door. They might say, okay, if you do a phone video with me to start with, or you do this phone intake to start with, I will be more happy to let you in my house. So we're seeing that as a possible byproduct of this, and that it might be a tool we can use later as well. So thank you very much.
Thank you, Brenda. Yes, I agree with you. We are all from different counties and face very unique circumstances. I think we are all taking many, many notes. We will now go back to Destiny. Again, Destiny is a promotora at Esperanza and has worked for a decade in South Los Angeles, serving the community as a case manager and promotora. Welcome again, Destiny.
Hi, can you hear me now?
Yes, we can hear you.
Okay, great. So, yeah, as a promotora, I've been working in the community as a promotora de salud as well as a community health worker. And with Esperanza, with our program, we have had to make very similar pivots as the other organizations that have been represented before me. And I'm not going to repeat a lot of the things. We definitely are doing a lot of the stuff that they're doing as well. So with our virtual home visiting, of course, none of this was in place before COVID. So a lot of this stuff we created on the fly. And like some of my other colleagues had said, that this is something that we had to figure out what was best for the community that we were serving. We were finding that a lot of people didn't have certain apps already downloaded on their phone, so we had to work with them with doing that as well. But we did notice that a lot of our clients did have Zoom because the children were using Zoom for school. So that particular app has been the most successful for us because a lot of our clients have small children, and so they had access to Zoom already. So a couple of the things that we have implemented was asking them about their COVID symptoms because we are dealing with clients with asthma. We wanted to make sure that they were not experiencing their asthma symptoms as well as COVID symptoms. So that was one of the first things that we had to incorporate in our check-in when we do our phone calls to see how they were doing. One thing that we begin to incorporate in our equipment delivery were thermometers because we found that a lot of our families did not have thermometers. And so we begin to use that tool as well and try to provide those to the households that didn't have them. I think that's just Asthma Management. Okay. Oh wait, some other devices are trying to come.
I think you should really get into get a reading, human design reading. I think it would be really beneficial. You're a 6-2, and 6 is like the Buddha. That's like your conscious self, and the Buddha, because it's like 1 through 6. The Buddha is the person who goes and retreats on the mountain to gain wisdom, and then comes back to the people and lives as an example for the people. And that's like your walking life, that's how come like you're probably wiser.
Maybe it is for the number says with the
Destiny? There is some background in the back.
A person to listen and to provide opportunity for self-care in that way. So when we, can you go back to the other slide? Thank you. So when we are doing the video and the phone visits, a lot of times it's not always education. It's also like a listening session. And we found that that's still the same when we're doing over the phone. People are still using it as an opportunity to talk because we're dealing with a lot of communities that have been historically affected by colonization. We are able to listen with a different ear, and we can hear the things that they are experiencing on multiple levels in society, and we can understand them in a more empathetic way. And so with our new protocols, as far as material delivery, we've been practicing the same things when we do the porch drop off, wearing our gloves, wearing our mask, but there are some barriers that we had to overcome. So barriers to enrollment, of course, have been getting access to the people. Clinics and hospitals have definitely been focused on COVID. So our enrollment has slowed down a lot because asthma isn't the priority, which is understandable. So there are certain clinics that are still able to send us new clients, but it has slowed down significantly. So we've been using a lot of this time just to stay in contact with the clients that are already enrolled, checking in with them to see if they're developing COVID or asthma symptoms, and to make sure that they are staying connected to their doctor and to their clinic to the best of their ability, and seeing how we can support them with that. Outreach, another thing that has slowed down. We've been doing our best to figure out ways to be able to outreach, but because of the stay-at-home order and things of that nature, it's really difficult to get out to the community in the capacity that we're used to or the capacity in which we desire. But contacting clients has been a lot easier because everyone is at home. So people are a lot more accessible and are more likely to return the phone calls because their lives have slowed down. So when we do get new clients and we call them, we have a higher rate of contact, which is beneficial. And we have noticed in that case that home visits over the phone do have their advantages because at this time, at least, because people are at home. But then we have the clients who struggle with technology. I had the privilege of working with a woman who did not have a smartphone, did not have a laptop, didn't have access to a computer. She was illiterate, so I couldn't just send her literature. So I did as much of the survey as I could over the phone, but when I did the equipment drop-off, I did have to do some education on the porch with her and pull up videos on how to take her medication. She had a new device. The doctor didn't have time to show her how to use that device properly. So she wasn't using it because it was really confusing for her. She went from an MDI to a DPI and with no instruction. So I had to sit with her. We had to pull up the video. We did it on the porch. She had on a mask. I had on a mask. I had on gloves. But that was the opportunity that I had to take in order for her to get the assistance that she needed because she was struggling with her breathing. She was experiencing chest tightness. And so I felt that it was really important for her to really understand how to use her medication. And I couldn't send her a video. I couldn't send her literature because she was a part of those members of our population who just cannot take advantage of those particular mediums. So face-to-face, me being able to explain it to her, watching the video was the best solution that I could think of at the time. And it worked. And she was very grateful. And I was grateful to be able to provide that service for her. So as I said earlier, and in agreement with what the other young lady said, that the 2-session option is what we do. We do the survey over the phone. We try to get as much information as possible. I have personally found that omitting some of the sensitive information, like how much money they make, or if they have private or government insurance, not asking those questions over the phone right off the bat have been most successful for me, because I feel like once you start asking those really sensitive questions about demographics, it may cause clients to get a little hesitant. So I personally started not asking those questions, just really focusing on how are you doing? How are you feeling? Have you been experiencing any asthma symptoms? Has any of this caused psychosocial triggers or anything to come up emotionally for you? So starting the conversation with really checking in versus just following the survey like it's business as usual has really given me access and caused people to put their guards down. And then if I need to get that information that's a little bit more sensitive, once we develop the relationship, I can always go back and get that information, because our program is a year long. So I can get that information later once they feel more comfortable with me and they feel like they know that it's not a scam, that whatever they're getting from me, it's not going to be billed to them later on, because there has been a lot of fraudulent activity going on and people are really leery about phone calls talking about their health and insurance and stuff like that. So I've really been careful to lead with questions that provided an opportunity for them to feel comfortable with the entire process. And once I get the survey done, we will schedule a follow-up education and trigger assessment phone call. Like I said, most of them I've been doing on Zoom, because a lot of the people already have access to Zoom because of the children using it for school. And those who do not, we use FaceTime. And I just have them show me what they feel comfortable showing me. If they don't feel comfortable showing me at that time, I'll have them describe it to me. And then if in the description they find I'm asking too many questions, eventually they just show me anyway, because they're like, okay, you're asking me too many questions here, just look at it. So I found that to be very successful for the most part. And yeah, I think that's pretty much it. We're doing the same things that everyone else explained. And those have been like the best practices, I think, for us at Esperanza.
Thank you, Destiny. Thank you for your descriptive information. And we appreciate your insightful information as well. We now want to move to our last but not least speaker, my dear colleague at Comité Cívico del Valle, Carolina Garcia. I've known Carolina Garcia for over 15 years, and so I have the pleasure of presenting her this morning. Carolina is a community health worker for Comité Cívico del Valle. She first began her journey as a community advocate for environmental issues in underserved communities, focused on air quality issues for the past decade. This led her passion to educate and advocate for issues affecting the health of low-income communities like Imperial County, as we are a border community. She is also an asthma self-management educator and is a trainer for the Asthma Management Academy. Welcome, Carolina, and the mic is yours.
Good morning, everyone. I'm very excited and honored to be part of today's webinar. As my colleague mentioned, I've been working as a community health worker here with Comité Cívico del Valle. I am very happy to be spreading asthma awareness, as this is a topic near and dear to my heart because I have 2 boys that are diagnosed with asthma. I do work for one of our projects, that's the Asthma Linkages Program. It's a program that is coordinated with our local hospital, Pioneers Memorial Healthcare District. And at the time of enrollment in the program, there is a consent form that is signed when they do a visit with our Asthma Care Navigator. Referrals are provided through the hospital emergency room or outpatient clinics that work with Pioneers. Our patients range from ages 5 to older adults. So today I'll be sharing a little about the outreach that we provide in the Imperial County. In case you've never heard of the Imperial County before today, I'll be sharing some quick facts so that you can get a better picture. We serve in an underprivileged community. We have a population of about 179,000, of which 35,000 are chronically homeless. About 83.4% of our community is Hispanic, and out of that percentage, 47.5 live in poverty. Our median household income is about $44,000 a year, and 43.8% of our patients have Medi-Cal insurance. Of our residents have Medi-Cal insurance. And just to have a comparison, the state has 48.6% of Medi-Cal people who are receiving Medi-Cal as a provider of insurance. We have 4,742 patients for every one primary care provider. And out of those people that are seeing a primary care provider, 23,000 children and adults have been diagnosed with asthma. Did you know that California approximately has 5.2 million people affected by asthma? 1 in 5 Americans can't afford their prescription medication. 71% of patients with asthma are misusing their medication. 3 out of 5 of those patients have limited physical activity due to their asthma, and 2 out of 3 asthma patients also have allergies. I just wanted you to know how important your role is as a community health worker. With your help, we can create a bridge of communication between patients and medical providers by delivering education and resources to families. We can help them achieve a better quality of life and empower them to be a proactive participant of their asthma self-management plan at home. We focus on providing guidance and support. We help the patient and family focus on what is in their control so they don't have to become overwhelmed, stressed, or anxious, making them feel proactive and motivated about their role while building a plan for their asthma self-management success story. Things that we help them with is recommending having a 30-day supply of medication on hand. We do refer them to our Facebook Asthma Management Academy for asthma and COVID content from a verified source. This is very important because there are so many sources on the internet and not all the information is always correct. We also go over their asthma action plan and how it's a tool for self-management at home. We connect them with community resources that may be preventing them from focusing on their asthma. We also help them reduce strong chemicals that are being used to disinfect. As you can see on the right side, we do have a COVID-19 prevent and protect guide. And this is something that we share with our clients. We also remind patients to stay healthy and active while in the quarantine. We talk about strong emotions because this can be an asthma trigger. We also talk about how breathing techniques can help reduce this trigger. And we share information that medical providers are still available via phone, teleconference, or curbside. We have had a lot of patients express concern that they're not able to see their providers, and sometimes they believe that they have no access because they're not able to go to the emergency room. And most importantly, We remind them that they aren't alone and they can reach out to one of our community health workers at any time. Adapting to a new model of home visits. So since the COVID-19 situation, we have had to change the way we conduct our visits to the home. We're making sure that the patient or client doesn't feel uncomfortable when receiving the information or materials for their education. We explain to the patients the process that's to be followed. We make an appointment to bring them the materials that we will work with during their education. We ensure that we wear protective gear like a mask and gloves. We notify them when we are outside in order to ensure that there is no physical contact. We try not to spend too much time at the patient's home. And if possible, we call again to notify them that we have already retired. So with our program, we've had home visits versus virtual visits. With phone visits, we do schedule a date to send materials via mail or drop off at the patient home, depending on what the patient feels comfortable with. In this packet, we include the modules that are to be covered, a patient handbook, the COVID-19 recipes, a community resource guide, and green cleaning recipes. For a virtual visit, we ask the patient what teleconference platform they are familiar with. We do get an email address where we can send them an invitation to the virtual visit, and then we're able to send the PDF document versions of the materials that would be mailed if it was a home visit. Virtual platforms that can be used are Zoom, Skype, GoToMeeting, FaceTime, Google Hangouts, WhatsApp, and Facebook Messenger. We offer options for our patients so that they are able to use a platform that they are comfortable with. In addition to the material that I listed here, we also provide other materials such as pillow and mattress covers, HEPA air filters, and our green cleaning bucket, along with our recipes for easy to make non-toxic solutions that are asthma friendly. Some barriers and challenges that we've had: only about 5% of our population has had virtual visits. The reason being is that fewer than 800 households per every 1,000 household have internet connections. A lot of our clients don't have smartphones, laptops, or computers at home. Some of our older populations have little to no knowledge of how to use technology. Some families also have never used a teleconference platform, and we also have an additional barrier that some families that have a concern with their immigration status sometimes have a problem getting the resources that they need because they have fear of deportation. When an HEO is completed over the phone, we have clients take pictures of the areas of concern, and they can send that to us via email or or text, or one of the platforms that I mentioned in the slide before. The schools have also been met with this challenge. A lot of them have had to provide laptops, tablets, and mobile Wi-Fi for people in our area, and also had to create webinars on how to use these platforms. These are some COVID-19 community resources that are available throughout the state of California. The Friendship Line California is for people that are feeling anxiety or stressed due to the COVID situation. They're able to call this phone number. We also have the California Department of Aging for our older citizens, the California Coronavirus Response Information Line, the Alzheimer's Association 24/7 helpline. We also included a way to find your local food bank because that's also something that we deal with. Sometimes clients do not have access to enough food, and with the COVID situation, some people are opting, especially our older population, to not go out and go food shopping because they are worried about their exposure since they are in the susceptible population. We also included how to find out where you can get COVID-19 testing and the California Smokers Helpline if we have someone in the home who may need to quit smoking, to help reduce a trigger for these patients. Here on this slide, you can see my phone number in case you have any questions or have any comments that you would like to address to me personally. There's also my email address, and we have Esther Bejarano. She's our asthma projects coordinator here at Comité Cívico del Valle.
Thank you, Carolina. Thank you for sharing one of your programs information. As we can hear, there is 4 wonderful programs that shifted abruptly. We couldn't wait. We needed to provide services and learn something new immediately. I know for Comité Cívico, that was our case. We knew that we had families isolated and needing our help. And so I want to thank all of you for your dedication, for your commitment, for your shift. I know we are still moving forward to provide the best service that not only works for our community, but specifically for each and every patient with now our remote platform. We want to move now to questions. This is going to be our Q&A session. We are going until 11:30 this morning. And so if you haven't sent a question, please do so. We will start with our first question. And this question is for Destiny. Destiny, how do you get the referrals to call these clients?
How do we get the referrals?
Yes, how do you get your referrals for clients?
Well, we have partnerships with a lot of different clinics in South Los Angeles. So we get referrals from St. John's Clinic, Children's Hospital, from Eisner, and other clinics in the community, Universal Health Center. And when they send us clients, when they send us referrals, we try to enroll them. Does that answer the question?
Yes, thank you, Destiny. The next question is for Anna or Mr. Hamilton. What ages of patients do you serve, and what online interpreting services do you use?
We serve cradle to grave. We generally do not take patients under a year old because asthma diagnosis at that point is really unclear, and those children really should see a specialist before being referred to us. We have taken a few who were 10 months or so at the parent's request if a diagnosis has already been made by a physician. As far as interpreting software or services, all our community health workers are bilingual in Spanish. We have a consultant group with Building Healthy Communities, Youth Leadership Institute for Hmong, should it come up. Those are the 3 languages we deal with the most often. And so we haven't as of yet required other language support. There are a number of language services via the phone. In the clinics and in the hospitals, we use those a lot. Some with great success, some with not so much. So.
Thank you, Kevin. This next question is for Brenda. Brenda, given that you don't discharge clients until you're able to do an in-person home visit, does this delay in any way affect the evaluation of clients' outcomes?
Yeah, it would delay the ending result. So we do pre and post testing on asthma knowledge and asthma control and ER visits and hospitalizations. So yes, it could impact when that final piece of the data would come in, but we just feel so strongly that it's important that we see the home at least once to make sure that there's nothing that we need to see that would be impacting their ability to have a good outcome over the long term.
Thank you, Brenda. And we have another one here for you. What billing codes are you using for face-to-face versus virtual visits when you do these visits?
Because we're not a clinic, we're not using a billing code per se. We invoice our managed Medi-Cal, and we do a different type of system for targeted case management, which doesn't require that. So it would vary. So if you were a clinic and you were billing for telephonic, there are codes. There's codes under Medicare, under Medi-Cal, and your individual insurer you were working with would be able to tell you which code they're paying under.
Thank you, Brenda.
Welcome.
Carolina, this question is for you. What is a COVID-19 recipes and where do you find these recipes?
COVID recipes are recipes that are that we worked on here with our staff to provide the most accurate information from sources like the CDC and the California Department of Public Health to help people in their homes be able to disinfect their home from the coronavirus versus what we normally share, that is green cleaning recipes that are a little less effective, I would say, versus the coronavirus. So there is a difference between these two, and we share this either with our clients via email, in person, and we also have it listed on our Asthma Management Academy Facebook page.
Thank you, Carolina. We have a message from La Vaca. Here at La Vaca, we are also wiping or cleaning products that we deliver to families. Is that a good method to prevent and control the spread of COVID-19? And that question can be for any of you.
Could you repeat the question, please?
I was going to ask the same thing.
Yes. Here at La Vaca, we are also wiping or cleaning products that we deliver to families. Is that a good method to prevent the control and spread of COVID? I think they're asking what would be the best method to prevent the spread of COVID.
Yeah, it's probably not a bad idea, but they're going back and forth on how long does COVID live on what type of surface. And some of the things they originally thought it lived longer on, they're finding it doesn't live as long on. So when we put a vacuum together or we put anything together that we're going to give them, we wear gloves so that there's hopefully not a cross-contamination. But if you wipe things down, it's not going to hurt. It could add to prevention.
What is a cradle to crave? Oh.
So let me just mention with the cleaning products, we do provide asthma safe cleaning products. The products we provide also are labeled to remove coronavirus. So there are a number of those products that are already on the market. The coronavirus was identified close to 50 years ago. As is mentioned before, people should know it actually causes the common cold. It's one of the viruses that causes the quote unquote common cold. It's been around for a long, long time. And so a lot of our disinfectants control it. The important thing, of course, is not to have artificial scents and disinfectants that have low vapor pressures, or that, in other words, have a really strong smell that might trigger our patient's asthma. So we're huge believers in that. Everything the patient gets delivered to them is wiped down with a disinfectant of that type before they get it. I'm sorry, somebody asked what cradle to grave was. I'm sorry, it's from my many years in the hospital and the clinic. It simply means we can't put a top end on the number. I can't tell you we see patients from 1 to 100 because people live to be 106, or somebody will ask me that. Well, what if they were 106? So we just use the term from when they're a little baby to any time up to before they have passed away. So a number of our patients, I would say at this point in time, probably 40% of our patients are adults. And of that adult group, over half are over 60 years old. So this presents a whole different group of patients than what many of the asthma home visitor programs are usually looking at, which is mostly kids, in my experience, or young adults. So it really forces our community health worker team to, and for myself, to provide better education for them on the complications that can come with asthma as people age out and start developing high blood pressure, congestive heart failure, diabetes. Mental health issues become significant with age, especially depression, bipolar disorder. All these things can make it a lot more difficult for that patient and that family, especially the families we serve who are either on Medi-Cal or have no insurance at all, to be able to take care of themselves with their asthma. Thanks for the question.
Thank you, Kevin. Apologies for abruptly asking that question.
No, not at all. It's a good question.
I think this came in for you. I have a follow-up question for that for you, Kevin. Do you use Doxy.me? And can anybody answer that if you don't?
Do we use what? I'm sorry?
Doxy.me for virtual visits.
We do not. Anna, you want to speak to that, please?
Yeah, so currently we are using Zoom, but we are open to exploring other options.
And this is Brenda. So we are looking at Doxy.me.
Brenda,
Yes,
can
we've
you
looked at
elaborate a little bit?
Doxy. By the way, we've looked at Doxy. It's a tool that's surfaced and it's been around for a while as well. You know, some of our patients, I think Anna would tell you, we haven't always been able to use Zoom. For some folks, it's really, they have a phone that happens to have a camera. So if they're able to walk around with the camera phone and connect to us, you know, then that's what we'll do when they're walking around the house. We have to be really flexible based on the patient's skill set. Again, I come back to my older patients. Many of them are not internet literate and quite frankly are frustrated by new phone technology, especially our folks who maybe didn't graduate from high school or even elementary school. So we find that we have to constantly be adjusting to compensate for those things and make sure that we're very patient with folks and help walk them through this, which is even more difficult in this virtual environment. But Anna especially has been leading on this, has been developing these new techniques, and has been hugely successful with it. I've been blown away by the number of people she's managed to get appointments with and see in this last month. So I just can't say enough about that. And all of you who are doing that right now.
Thank you, Mr. Hamilton. We do have several questions coming in. I will jump to the next one. And this one is for either of our presenters. Do you have different processes for the drop-off when family has COVID-19? We shared that we are dropping off at the doorsteps. And so the question is, do you have uh, any different processes to drop off when the family shares that there is a COVID member?
This is Destiny. So far, I haven't encountered any client with COVID or a family member with COVID. So we do ask the question, has anyone been diagnosed or have been having symptoms? And by and large, I haven't had any issues with it at this time. So I haven't had to implement any different protocols besides the safety measures that we have already put in place just to prevent the spread or exposure.
This is Anna with the Central California Asthma Collaborative. I also have to agree with Destiny. We ask the questions as well, but that's not something that we've encountered so far.
Thank you, Anna and Destiny. This question goes for Carolina. How are you recommending patients to stay active in shelter-in-place orders and curfews?
So what's great about a lot of our access to technology for those families that do have access is that there are a lot of YouTube videos that people can use. I know personally, my son gets YouTube videos from his PE teacher to do certain exercises every day of the week. So that is something, but we also share over the phone different activities that they can try. We do also, like I mentioned before, we talk about maybe yoga or some type of breathing techniques for people that are experiencing a lot of anxiety, because that can be useful. Another thing that I also try to express with patients is that self-care is very important. I know a lot of mothers that are part of our program feel like they are feeling all the stress and pressure from working from home, doing homework with children, and sometimes they need one activity, maybe for a few minutes a day, to kind of refocus on themselves and take that moment of self-care. And if we take care of ourselves, we can take better care of our family. That's something I like to share with them.
Thank you, Carolina. This next question goes to any of our speakers. Does anyone inspect the home to look for home-based asthma triggers? What are challenges now with the COVID-19?
This is Destiny
Anna.
and Anna.
Go ahead, Destiny. Go ahead, Destiny.
So yes, we do. Well, we're not doing any inspections personally, but we do our best to do them over the phone. So we guide our clients to show us particular areas like underneath the kitchen sink, or like around their room, their roof or their ceiling, not their roof, their ceiling, to see if there's any leaks. Also in our survey, we ask different questions like if they are having any structural damage, leaky roofs, tubs stopping up or sinks leaking, mold or mildew. So we ask those questions in the survey, and if they respond yes to any of those questions, we ask those who are comfortable to show us or take a picture or show us on video where those problems are, and then we help to guide them through remediation. Normally we're able to advocate for them. We will write a letter to their landlord, those of them who desire a letter, because not everybody wants to fight that battle. But those who are interested in being referred to housing organizations like STAGE, we will refer them, and we can also write a letter of advocacy on their behalf as well. So we do our best virtually for them to show us different things in their homes that are extremely identifiable triggers, and then just kind of do like a pan of their room and the living room and see what we can notice and different things that we can educate them on virtually.
And this is Anna with the Central California Asthma Collaborative. So we also do virtual visits, and we're able to do that through video. some of the challenges that we have encountered, for example, would be like if someone needs to get down and look under their fridge to see if they have a drip pan, that has been a little bit difficult. Or if the lighting in their home hasn't been the best, sometimes it's a little bit difficult to see if that's mold. But we ask them if they can take a picture, or if they have a flashlight that can be used. And also, we also send them and help them write a letter to their landlord if that's something that they are interested in. So that's what we've been doing virtually.
Thank you, Anna. We have a question for all who you have experience working with enforcement agencies in addressing those aspects of triggers, pest mold that cannot be fully resolved by families, such as the pest control issue. Families can take preventative action, but some triggers may require additional action beyond the family's capacity. Does anybody have some insight on that question?
This is Brenda. Because we're the public health department, we also have an environmental health department, which is a part of pest control, and we are able to call upon them to go in and work with the landlords if there's pest control things that are needed. If there are American Disabilities Act, because AsMA falls under that, so such as carpet removal, we will get the American Disabilities Act form filled out, and you can get permission for carpet removal. Most landlords will let you go with it, but they won't necessarily pay for it or pay for the laminate afterwards. So that's something you have to work on.
Thank you, Brenda.
For us at the Central California Asthma Collaborative, aside from helping them write that letter to their landlord if they're interested, if they are comfortable, we also encourage them to make a report with code enforcement if they are comfortable with that.
Thank you, Anna.
I do want to mention that there, if I could, there's a bill, a healthy housing bill in Sacramento, the number escapes me right now, that would allow patients, families in low-income rental or any rental property to go ahead and, after notifying the landlord, if the landlord doesn't respond, make repairs and deduct that cost from their rent over a 3-month period. It is being, you can assume there's a lot of fighting going on with this, but it is actually moving. And while it may be shrunk down a little bit, a lot of us have great hope that that might pass. That would be a game changer for these folks, for many of these folks.
Thank you, Kevin. We have one question that just came in from Utah. It says, I work in Utah at a county health department, and we are exclusively using Doxime for visits. It works really well, it's HIPAA compliant, and we also have a BAA. Our legal team has approved them. We have also changed our consent forms. Yeah, and so she's adding, we have also changed our consent forms to include telehealth and verbal consent.
I was teasing and saying, can your legal team talk to ours? That's been a big thing, is to try and get the one thing that they'll allow us to do as a public health department, the one system they'll allow us to use.
Thank you, Brenda. We have just a few more questions before our time is up this morning. And this one is for anyone. Can anyone share a success story during the COVID crisis when providing a home visit?
Sure. This is Carolina with Comité Cívico. I can share a success story. I had a patient when we first started our home visiting program. This was prior to COVID. She had a lot of problems with having good self-management at home. We did one initial visit prior to COVID, And then since she was no longer working, it was easier for us to schedule the following home visits via the phone. So we were able to get her to to follow her asthma action plan, to identify her triggers, to reduce exposures in the home, and also we coordinated so that now she is under very good self-control. She was very happy with the program. She even spoke herself and said, I remember when we first started, I had about 6 asthma episodes where she was continually going to the ER. And since we started the education program, she expressed how she was able to talk to someone because she was afraid to go to the physician due to the COVID-19 exposure. She was able to make a lot of changes, and now her asthma is very well under control. And she's very grateful for the program and all the resources that we've been able to provide for her, and also just the support, because she was feeling a lot of anxiety due to the COVID-19 situation. And we also connected her with the resource where she was able to kind of express those concerns with a professional, and also with our recommendations of things that she can do for self-care. She was able to find a balance.
This is Destiny. One of our clients that we received from Children's Hospital was a little boy, and he was having asthma symptoms daily and had gone to the emergency room a couple of times. And after doing the home visual assessment, I was able to see that there was a roach infestation. And so one thing that we do is provide education on decreasing or eliminating the roaches from the home. And we do this by using a product called Advion, which is a non-toxic gel bait. And normally we would go into the home and place the gel bait down ourselves, but during this time we're not able to. So we have been providing the syringes to our clients and just doing like a tutorial online for them to see how to place it down properly. And the mother was able to do that, and she has seen a significant decrease in the roaches in the home, as well as in his asthma symptoms. And in addition to the gel bait, we were also able to provide an air purifier for him to have in his room, and that has really helped him manage his symptoms.
And this is Anna with the Central California Asthma Collaborative. So we have seen a lot of success, mainly from folks just being relieved that there are resources that are available to them. We have had a patient that we did enroll just recently that we did do the virtual visit, and just helping them connect to those resources in their community that they were not aware of. They were facing food insecurity, and so that was something that was triggering their asthma as well, as it was providing a lot of anxiety from where their next meal was going to come. So just helping them connect to those resources in their community, and getting them scheduled with their provider and encouraging them to go in. So that's something that we're still working on, but we have seen an improvement, a self-reported improvement from that patient.
Thank you so much, Anna. And I think we're out of time. I do want to thank our webinar speakers today. This is a new journey for all of us. It's a transition, and I hear that you are all very passionate and dedicated to move forward. And thank you for your presentations, for your knowledge and expertise. Anna, Kevin, Destiny, Carolina, we thank you all for this morning's education for all of us. Please fill out the evaluation when you sign out of the webinar. If you have any questions, feel free to reach our presenters. We will be sending this, we will be recording the webinar, and so you will be able to see their contact information. We hope you will continue to participate in future webinars with the Asthma Academy webinar series. Please stay safe and healthy and have a wonderful rest of the day. Thank you, everyone.
Thank you.